Good afternoon, everyone. Thank you for joining us today. We're really very happy to have you here with us today. And we are very pleased, very honored to have Dr. Lisa Case join us today and give us a seminar. And she is an associate professor in the psychology department at San Diego State University. And she earned her PhD in industrial and organizational psychology from the University of Connecticut. And I also like to mention her PhD and master degrees in IO psychology, but the undergraduate is in chemistry. Very unique, yes. And she is an occupational health psychologist, and her research has been focusing on safety and job stress. And her research has been cited over 2,000 times and have been published in very important journals in our field, such as Journal of Occupational Health Psychology and Safety Science. And she is a past president of our Society of Occupational Health Psychology, and she currently is an associate editor for the journal Occupational Health Science. So without further ado, let's welcome Dr. Lisa Case to join us today. Yeah, thank you.
Thank you. Thank you guys so much for having me out. It is just definitely a pleasure to be here. It's my first time to visit Portland, so I am delighted to be able to see the city, although it's a little cloudy, so I don't maybe get to see quite as much as I might see another time. But I've already been convinced to visit in the summer so that I can see the surrounding mountains a little bit better and maybe get a little bit of sunshine. Is everything good? Okay. I'm really happy to talk to you about my research on patient aggression towards healthcare workers. Oh, okay. Sounds like a small dog. Didn't it kind of sound like a small dog? Okay. Okay, thank you. Okay, so I am excited to talk about my research on patient aggression towards healthcare workers. And as Dr. Wong was so nice to point out, I started out my career as an organic chemist. So I got my undergraduate degree in organic chemistry and then worked in biotech and big pharma for a few years before switching and becoming an organizational psychologist. Now, the reason that this is at all relevant to what I'm going to be talking about today is that as an organic chemist, I went through lab safety training a lot of times. Every time I started a new lab, more lab safety training. And I think that I've brought that interest in safety with me into my job as an organizational psychologist. And I've done research on worker safety with populations like railway workers and grocery store employees and things where I'm just interested in the psychological processes that contribute to worker safety. Because what I noticed when I was an organic chemist is that I would get trained on how to do things, and then I would walk into the lab and I would choose which behaviors I wanted to use. I could decide to wear my safety glasses or not. I could decide to wear my gloves or not. And what I did was I looked around to see what my peers were doing. And that social influence on my safety behaviors I thought was a really interesting. Closer. Okay. All right, thanks. I literally told him, I said, whenever, takes a lot to get me off my game. So that is something that I think just really piqued my interest in terms of like the psychological processes that are related to worker safety. So then in 2007, I think, I met a nursing researcher. That's not her, that's just a stock image. But I met a nursing researcher who was interested in collaborating on some research. And she was interested in leader stress in nursing. And so that's what pivoted me towards studying healthcare workers. We launched in 2008 the Nurse Leader Stress Study, which we conducted at 35 hospitals across the southwestern US. I won't tell you how many IRBs we had to go through to get all of this approved. It was a lot. Make good choices. But this Nurse Leader Stress Study helped to really introduce me to the world of healthcare workers and what their challenges were like with regards to safety and with regards to stress. And I just found it to be really, really interesting. And so maybe in part because of this experience that I had, I met somebody on a listserv, which I know is a strange way to meet somebody. But in 2013, I entered a collaboration with Dr. Jonathan Burleson, who's an IO psychologist like me. but he works at St. Jude's in Memphis. And we collaborated on a study using multi-level modeling of this AHRQ patient safety culture data. And so that also introduced me a little bit to the world of patient safety. So our collaboration turned into a friendship and a publication. And eventually, there's this consortium that St. Jude's and other children's hospitals are involved in called the Solutions for Patient Safety. This is a consortium that's got, I think, over 120 children's hospitals associated with it. And so they have decided they're not going to compete on patient safety. They're going to share their data. They're going to figure out ways to improve patient safety, and they're going to share that information across all these different children's hospitals. So a really interesting type of collaborative venture that you don't often see in organizational research. So Dr. Burleson was kind enough to recommend me. In 2017, the Solutions for Patient Safety group had this realization that they could focus on employee staff safety as another way to improve patient safety. And so making this connection was relatively new for them, but also really important. And they were looking for somebody to be an embedded researcher with them to just help generate new information. And so in 2017, I became that embedded researcher, which came with a whopping salary of $0, but that's a whole other issue. But access to an enormous amount of information and connection. And I really spent 2 years listening to what was going on with these children's hospitals. So the way that they were approaching the situation here is that they were looking at issues of overexertion, so oftentimes safe mobilization of patients. They were also looking at slips, trips, and falls. Hospitals often have moisture on the floors, which we will not discuss any further. We'll just keep moving right along to patient behavioral events. This is what children's hospitals refer to as patient aggression. So they tend not to use the phrase patient aggression because it can imply something negative about the patient and their intentionality that is not, they don't really think that that's appropriate for children, which I think makes a lot of sense. So they call these patient behavioral events. Now, I had already done a little bit of work starting to explore this overexertion area, and I assumed that's where my research was going to go because I had already started to do some work in this area. But as I listened, what I realized was the area of greatest need and greatest curiosity was on this patient behavioral events side. And so I pivoted my research to try to focus on that instead. And launched a study, and that's what I'm going to be telling you about is this first study that we did looking at patient behavioral events, just trying to understand that situation a little bit better. So the way that we define patient behavioral events for this study is adverse patient behavioral events include any instances in which a patient has been physically aggressive toward you or your colleagues, even if you thought it was unintentional or did not cause serious harm. So we were not requiring that there be any intent inferred on behalf of the patient, and it didn't have to lead to physical injury to you to qualify as a patient behavioral event. Now, there is one word in this definition that I want to point out to you. It's the word physically. So we are focusing on physical aggression because at the Solutions for Patient Safety, what they were tracking to determine the success of interventions related to patient behavioral events was the workers' compensation data. So things like days away, restricted or transferred, or the total recordable incident rates. These were most associated with physical injuries. So we focused our study in terms of physical experiences of patient behavioral events. So the aims of this study were to look at the psychological effects of patient behavioral events. So we could see that there were documented physical effects, but we also knew that there were likely to be psychological effects, but they weren't well documented. So we wanted to look at 4 major things here. We wanted to take a look at the frequency versus the severity of these events and try to determine whether a lot of lower level events might be also associated with psychological harm. We were interested to see if there were ripple effects. So when something happens to me, does this affect my coworkers psychologically in any way at all? Are there any protective factors that we might be able to identify? And then also, what are the perceptions of the avoidability of these events? Do people believe that these events can be avoided, or is this just a part of the job? So these are big picture the aims, and I'm going to walk through each one of these things, and I'm keeping the numbers the same and everything, so we'll be able to follow along. But when I talk about psychological effects, that phrase is doing a lot of work. So when I am talking about that, I'm talking specifically about these three main categories of outcomes. So we measured a lot of outcomes. We measured stress outcomes. So we measured things like emotional demands, the extent to which your work feels emotionally demanding to you. We took a look at work pressure, which is basically like just your job stress, and we took a look at burnout. In addition to stress outcomes, we took a look at 3 work attitudes. We looked at overall job satisfaction, your engagement with your work, and we looked at your attachment, your organizational attachment, or more specifically, your hospital attachment, to see what those work attitudes were like. And then we also took a look at 2 categories of what I'm calling work behaviors. This includes work withdrawal. So these are the ways in which people might withdraw from their work if they're, oftentimes as a response to stress. So it can be things like showing up late to work or calling in sick. And then we also included intent to quit, which is not technically a behavior, but it's a precursor to a behavior. If you think about it, people who quit aren't able to take our survey. So we're just trying to measure what happens before that, which is the intent to quit. So it's kind of the best we could do under the circumstances. So you will see these 3 categories again. But let me give you some information about how I'm organizing this presentation. The blue is going to be the introduction to the section. The green slide, so it'll be just like this, but green in the background, is going to be the summary and the indication we're moving on to the next set. And I'm going to have some takeaways on the green slide, so just to orient you and give you some sense of progress so you don't feel like you're trapped here forever. Okay, so with regards to some basics, who does this represent? So we did this study with healthcare workers who provide direct patient care. We really wanted to make sure that we were surveying people who were likely to be bedside, and obviously that can include people who are primarily bedside and then people who may be bedside a little bit less often. But if you were a healthcare worker who provided direct patient care, then you were eligible to take this survey. We did this survey with 3 children's hospitals in the United States. So we were able to get 3 that were interested in participating and learning about this. We recruited a total of 490 participants. Response rate is very difficult to calculate because in some of the hospitals we asked specific units, and it might be easier to calculate their response rates, and it was kind of more person to person. You were invited to participate. But at another hospital, they were more emailed the entire nursing department. And they're like, it's just much harder to see, who's getting these. We estimate the response rate is around 18%, which for a study like this is not that bad. These 490 participants, we also did something called multi-level modeling, where we wanted to look at some social effects on individuals. And so we had these people categorized into groups. And what is your natural work group can be a little bit complicated for some of these participants. But what we settled on was people that were in the same unit and also on the same shift. As probably the best way that we could categorize this. So we had 490 participants. They were in 44 unit shifts, or basically work groups. So that's who the sample represents. Also, I should tell you, anytime you guys have questions, feel free to interrupt. Same thing for the chat. If you've got questions to put into the chat, that's fine. And I also have time left at the end to answer questions as well. Okay, so we wanted to take a look and see how the outcomes were. I showed you all those outcomes that we measured. And in general, the outcomes looked pretty good. So the job was found to be stressful, which is not great, but the job had a lot of emotional demands, also not great. The rest of them looked pretty good. And I have to say there's really nothing unexpected here. The job is stressful. The job does have a lot of emotional demands. And so in my previous research with healthcare workers, we saw these same kind of results. This is exactly what we expected to be the case. We also wanted to look to see how bad are the PBEs. So we asked with regards to a frequency, it was a subjective frequency scale, and we were asking people, how often have you experienced these patient behavioral events? And when we talk about personal experiences with patient behavioral events, what we found is that the frequency that was reported was in the middle. So it wasn't never and it wasn't always, but it was sometimes. Again, probably what you might expect. And that the frequency this frequency with which this happened and it resulted in physical injuries happened less often, rarely or sometimes. So again, this is what you would expect. And this gave us confidence that the way that we were measuring this frequency captured even these lower level events that weren't considered to be severe, but that maybe happened quite a bit more often. And so that is expected. We also measured whether people witnessed or heard about patient behavioral events and the frequency with which they've heard this. And so the frequency here again was sometimes, injuries rarely or sometimes. So what we're seeing is that people are not only experiencing patient behavioral events, but they are also witnessing and hearing about patient behavioral events. So that's all kind of good basic news for our study in trying to understand these experiences. Oh, yes.
Were you able to match the surveys with the workers' comp data?
We were not able to match the service with the workers' comp data. We talked about it and decided we did not have 5 years to manage the coordination of the individual surveys with the workers' comp data, but it is something that we would be interested in taking a look at sometime because I do think that would be, I also think it would be interesting even just to follow people up after they've had an incident, you know, and interview the whole unit, for example, and see what their responses are. So I think there's a lot more that could be done for those kinds of situations, but this is all survey data and not connected with outside data. Thank you. Any other questions before I keep rolling? All right. We asked them about the rate trend. Do you think the patient behavioral events are on the rise? These studies, the surveys were sent out in 2021 and 2022, relatively recent, but not like, you know, last year recent. There was a moderate sense that patient behavioral events are on the rise. And from what I've seen in the literature and anecdotal discussions with other people, that continues to be the case. So this isn't an issue that's in the rearview mirror for healthcare workers, but it's still very much a concern still. So here's my green slide. In summary, the data shows us that the people that are in our sample are not in full crisis, but there is some reason for concern. The job is stressful. They're experiencing patient behavioral events. So there's definitely something here worth looking into. So then we move on to our first question, which is frequency versus severity. Do only the really big events matter? So for these patient behavioral events to really count for causing psychological harm, is it really only the big events? The way that we measured frequency versus severity, and I understand that measuring severity there are other ways to measure it, but the way that we chose to do this was how often did you personally experience patient behavioral events? And again, this is a subjective frequency scale. So if you feel like it's often, you report it as often. We felt like that was the best way to capture the psychological experiences of these events. And then how often did patient behavioral events result in injury or bodily damage to you was a way to capture how, you know, to what extent are these leading to some level of severity. Yeah. Okay, so repeat the question. Yes, thank you. I just remembered that. So the question is if you've got a patient in a clinic that you're seeing, you know, 5 days within a week, and that person is, you know, having a patient behavioral event every day of that week, does that count as one, or does that count as multiple events? And it's a great question. The way that we are capturing this is not by a count of events. So we didn't want to ask people to count the number of events. We wanted them to be subjective and saying, yes, this happens often to me. So it's descriptive more than it is like a count. And so and one of the downsides of this is that, you know, it's subjective. And so if as a worker, I am showing up to work and I know this patient's going to be there and I'm seeing this happen a lot, and you ask me if it's happening often, and it doesn't really faze me that much, I might be more inclined to say sometimes rather than often, whereas somebody else might experience the exact same behavior and say that it's often. So it's kind of a trade-off. Like, we went back and forth with the measurement on this, whether to ask people to do a count or to ask people to do a subjective evaluation of, this feels like it's happening often to me. And I think that the reason that we landed on this subjective measurement is twofold. Number one, your subjective perception of it is going to be most related to your psychological effects. Also, there are known, and in our case, documented differences in exposure to patient behavioral events depending on what kind of unit you're working in. So if you're working in the emergency department, if you're working in the psychiatric department or psychiatric unit or behavioral health unit, you're much more likely to see these things. And if we did a count, then we were really worried that we were going to be confounding, are you working in a behavioral health or emergency department, or are you working in a med-surg unit? And we didn't really want to confound that. So does that address your question? Maybe more than what you were looking for, sorry. Okay, so this is how we measured these two things, and what we were interested in was the association between these things and these different outcomes. So we were looking at psychological effects very broadly across a wide number of outcomes, and the way that we looked at this was correlating the responses to these patient behavioral event questions with each of these outcomes. So now I've made a conscious decision to not put a bunch of numbers on the slides here. I wanted to keep this at a conceptual level. I love the numbers, so if you want to talk about the numbers, I'm happy to talk about the numbers. But I want to keep it at a conceptual level because I find that the numbers can be really distracting for people who, I wonder if that correlation is significantly bigger than the other one, and then you're off and thinking about all these things and I've lost you. So it's going to be a numbers-free research presentation, but if you're curious, let me know. We can talk about that from a numbers perspective if you're interested. What you're going to see, though, is that for every significant correlation we have between these two items of frequency versus severity and each of these stress outcomes is going to be represented by a check mark. And I'm going to call your attention to 3 stress outcomes, 3 work attitudes, and 2 work behaviors, because it's a pattern you're going to see on the next slide and then subsequent slides after that. So when we get to the results here, what we're looking at is we've got these stress outcomes, these work attitudes, and these work behaviors. Those are the 3 categories. And this is for the experiences of patient behavioral events where you are the target. So this is your personal experiences of patient behavioral events. And the main question that we wanted to ask is, are there check marks under frequency? If it was only the incidents where there were injuries that were going to lead to these outcomes, then we would expect that frequency wouldn't have as many associations with it. And what we find when we compare these two, obviously, is that there are plenty of check marks. In fact, all the check marks underneath frequency. And because we have a reasonable confidence that we have captured these lower level events, then we feel confident in concluding that frequency of these events is associated with these psychological harm indicators over here. Now, what I don't want you to do is to overinterpret the number of checks here versus the number of checks here. That's very likely to be a statistical artifact, so don't get excited about that. We were really just interested to know, are there check marks here? And indeed there are. So the takeaway here, the question, do only the really big events matter? The answer is that high frequency of patient behavioral events is associated with negative outcomes. And so this does indicate that even the accumulation of smaller events can really influence your psychological experiences at work. All right, so now we're moving on to ripple effects. And do these events affect anyone else? So when you are witnessing or hearing about these effects, is that associated with anything? So we ask the same questions, but we ask them with regards to whether you witnessed or heard about PBEs. And so how often did these result in injury to your coworkers? So again, about these experiences that are happening to those who are around you. And when we compared the results here, when you are the target of patient behavioral events and when you witness or hear about patient behavioral events, the question that we're, is there an issue? I got out of range?
That's perfect, right there.
Okay, thanks. I need a lot of handling, apparently. It's not surprising to anyone who knows me. Okay, so then the question is, are there check marks under, witnessed, or heard about? And so when we compare this, if witnessing or hearing about patient behavioral events wasn't going to be harmful to people, if there weren't ripple effects, then we would expect that there wouldn't be that many check marks here. And indeed, there are a lot of check marks here. So again, don't read too much into the number of check marks in each. We're not going to be worried about that. But the takeaway here, do these events affect anyone else? These results suggest that witnessing or hearing about patient behavioral events is also associated with negative outcomes.
Do you know if at any of the hospitals or if they do regular huddles where they would discuss these things?
That is a great question. So the question is, do I know if in these hospitals, whether they did regular huddles where they may have discussed these things, which would have disseminated this information more widely? And the answer is I don't know, because in some of the hospitals, it was just, a big blast across, all the hospitals, or all the units, I should say. I don't know. And it would be a really interesting moderator to see if that moderated that relationship. It might give some indication.
There might be like some support there too.
Yeah. So it could disseminate the information, but then also, what do you do with that information? Yeah, there's a lot there. That's a great question. And something that we would be, happy to look into, I think, in the future. That's great. Any other questions? Yes.
So for the experience versus the witness,
Yes.
did you separate it out for people who never experienced but had witnessed, or because otherwise it feels like maybe it's the same. How do you know which is driving if people are experiencing it?
We expect that people are probably going to do both, and it's. Oh, I'm sorry. Yeah, thank you. So the question is how can we separate out the people who have been targets of PBEs versus the people who have witnessed or heard about PBEs? And I think the best way to think about it is we're looking at the association of the frequency of these experiences with these psychological outcomes. And so the frequency with which you witness or hear about it, does that have an association with outcomes? And does the frequency of experiencing it, how does that associate with outcomes? Yeah, that's a great question. So thank you for asking that. Any other questions? Okay, you guys are a fun crowd. Okay, we've already done that slide. So now we're moving over to protective factors. We looked at two. They wouldn't let our survey be 8 million pages, so we had to limit it to some extent to just a couple of protective factors. So one of them we were interested in was emotional authenticity. So we were thinking about these experiences in children's hospitals. And, you have to engage in a lot of work in children's hospitals to put on a good face for the patients, for their families. And when you've had these aggression experiences that, you still have to put on a good face, is it helpful to be able to, with your coworkers, be able to be more of your emotionally authentic self? So if you've got a patient who's a handful, you have to be calm and not frustrated and really manage yourself. And is it helpful to be able to have coworkers where you can go and take the mask off and just be yourself? So that's what we were interested in, taking a look to see if that was helpful, and also interested in taking a look to see if the unexpected events were more upsetting. So these were two of the protective factors that we looked at in this study. So this was the multi-level modeling part of our study. We looked at something called the climate for authenticity, which is the sense that within your work group, you can be emotionally authentic with them. And so we were able to aggregate this measure to the 44 unit shifts that I talked about earlier, the work groups. And it's really your question about, managing and hiding your emotions from your patients. Then that's kind of a normal part of the job. The question is, do you have to put on a smile for coworkers too? Or can you, take that mask off backstage? And we thought that maybe that might have a protective effect. Unfortunately, we found that it did not have a protective effect. So we did all that multi-level modeling for nothing, but that's science. So we move on to the next protective effect that we were examining, which was expectations. So patient behavioral events are often expected, and we asked this in the survey to see how often they were expected. Yes, sometimes you know this particular patient's going to be a challenge, or you know that working in the emergency department might be kind of rough. What we found is that across all of those outcomes, these expectations really didn't have much of a protective effect. But I also said mostly had no effect. That means they had a little bit of an effect. So when they did have an effect, these expectations were better for two outcomes. Number one was your attachment to your organization or to your hospital. So if you were expecting these events, then you were more likely to be attached to your hospital and more likely to be intending to stay. And so the thing that I want to, well, I'll walk through this. The thing that I want to warn you about is that I was trying to find a picture that captured what it meant to expect a patient behavioral event, and I could not find a human facial expression for this expectation. So I'm not trying to imply that healthcare workers are dogs in any way, but this was just like the best expression that I could find. And so if you are a little bit suspicious or expecting that maybe there might be a patient behavioral event coming your way, when that happened, then you were more likely, if you experience this patient behavioral event, to be still attached to your hospital and still intend to stay working at that hospital. So it didn't, in summary, what about these protective factors? Emotional authenticity was a complete bust, but in limited situations, expectations can help, but mostly expectations were not that helpful for these outcomes. More just in terms of your ability to, want to stay attached to your hospital and to not want to quit working there. It is very exciting.
Just clarification, so those expectations for such patient behavioral events, is a moderate duration of experience, even and the outcome.
Yes. Thank you. That's a great question. Of course, you're asking the tough questions. The question is did the expectations moderate the relationship between experienced patient behavioral events and outcomes, or witnessed or heard about, or those secondary experiences? And it was with the former. So we were looking at just the personal experiences, because we were really trying to find, the people that are targeted are going to be the most affected. And so that's where we wanted to really drill in on the protective effects. So thank you. Any other questions? Yeah.
Any sense of where those expectations of having that events occur, or the training?
Yeah, no, that's a great question too. Where did these expectations come from? So we didn't ask specifically about that in the survey, like where did these expectations come from? But I know from talking and listening to the healthcare workers that they come from a variety of different places. Sometimes you will have a child who's been on a unit for a while, you know their behavior, and you know that this is something that's likely to happen, with them because they have a history of this. At some hospitals, they have a flag in the EMR, the electronic medical record, to show you that this patient has a history of having patient behavioral events as kind of a heads up to the healthcare workers who may be interacting with them. And then sometimes there are some warnings from patients or from families or caregivers, and they may say, hey, just so you know, my kid likes to kick when they're going to get a shot. So just be careful about that and make sure you're around the side. Yes, that's a great question.
Guessing there's also other unit type differences.
Definitely. Yeah. So like I said before, the question is, are there unit and type differences? The behavioral health units and the emergency departments absolutely have higher expectations of this. And that's been shown not just with this sample, but also just nationwide and I think worldwide. That those two units are most likely to experience patient aggression, and that's both pediatric and adult. Yeah, great questions. Yeah. Well, what's interesting is we didn't do that, although that would be an interesting thing to do. The question was, did we control for those unit memberships in our analyses? And we didn't, but we could. because it was a subjective frequency scale, one of the things that's interesting is if you are in a unit where you don't experience as many actual patient behavioral events, you might still feel like it's frequent because it's happening more often than you expect in your unit. So it's kind of a complicated issue. Doesn't mean that it wouldn't be fun to look at that though. So, okay. Any other questions or comments? I'm trying not to drift out of frame. Okay. So the last thing that we looked at for this study was avoidability. Do healthcare workers think that patient behavioral events are avoidable? So this, we determined, was an interesting question to ask because, again, in talking and listening with these healthcare workers, one of the things that, that we heard that a lot of healthcare workers believe is that these types of events are part of the job. Nothing can be done about it. This is what you signed up for. And if you can't hack it, get out. And that's just the way, that's a belief that a lot of people have. And so they were curious to know, the hospitals were curious to know, what are the perceptions of the healthcare workers that are going to be in the sample, and do they think that these events are avoidable? So when we took a look at this question, most were in the middle. So most were neither agree nor disagree is where the average landed. And actually that was great because on the one extreme, if you believe that every single patient behavioral event is avoidable, then you are frustrated anytime something like that happens and you're looking to figure out how to, who's to blame for this, for happening. So the attribution process is going crazy. And probably that's psychologically kind of a rough place to be, is thinking that they're all avoidable. Likewise, though, if you think that none of them are avoidable, then you're helpless in that situation. You have no control. There's no sense of agency. That also has been shown to lead to a lot of bad stress outcomes. So, we don't think that that's a really good place for people to land either. So we were heartened, actually, by these results with them being in the middle. We think that that's probably a good place to land. We also, because we're a little nosy, asked where do you think the responsibility lies? And we asked this, how much do you agree with, these different sources as the responsibility for these behavioral events occurring in the first place? And here, what the hospitals were most curious about was self-blame. And they were concerned about whether healthcare workers were having these events and then thinking, I could have done something different. I should have done something different. I triggered this kid and I know better, or whatever. And they were concerned about that. Luckily, the results show that there was really not as much self-blame as they were thinking might happen. So that's good. When we look at the next layer of most frequent attributions for responsibility here, it's with other healthcare workers. So this is situations like where maybe a nurse is providing regular care throughout the shift. A physician comes in, doesn't know the patient, doesn't know the triggers, accidentally triggers a patient, and then then there's a patient behavioral event. So that type of thing can happen, or maybe at a shift change or something. So that. Oh, hello.
Hi, Dr. Kapp. We had a question in the remote participants.
Great.
It's from Ted Sharp. Apologies if I mispronounced that. The question is, so standardize each unit on actual frequency of events against workers' perception of events. Then compares across units based on recorded frequency of events. Or do you have data only for workers' perception?
That's a great question. So thank you, Justin, for asking. Thank you, Ted, for asking. And the answer to that is we did not have objective data for the number of events that were happening on a unit. And they don't have good records for that, is the bottom line. So as you might imagine, if you're working in a behavioral health unit, if you had to report every single incident that happened, you would be reporting all these incidents and not providing much patient care. So the data was pretty poor, so we didn't have an opportunity. If we ever come across that data, we're on it. So it's a great question. And we're dreaming for the day that that data is easy to collect and available for use. Thank you. Okay. So with regards to responsibility, the most frequent culprits, if you will, of these patient behavioral events were family members and the hospital itself. So family members, that makes sense. I mean, frankly, family triggers some of us sometimes too, right? So family can be a lot. And that's also true in hospitals, very high stress settings. The one about the hospital was very curious. So there was a sense that the hospital is responsible. So I asked these participating hospitals, what do you make of this? And they had some interesting ideas. So one of them was that the processes sometimes are very cumbersome. And so you might, as a patient, come in to do something, and then you have to do some paperwork, and then you have to wait, and then you have to get into a different room, and then you have to wait, and then you have to have a procedure, and then you have to wait. And that the clunkiness of these procedures might add to the frustration of the kiddos and or their families, and that might cause the kids to be triggered and a patient behavioral event to occur. So that's one thing. The other thing is availability of PPE, so personal protective equipment, might be a way in which a hospital could be responsible for these incidents and people not feeling safe. It can also be a lack of de-escalation training. So training healthcare workers to de-escalate patients and giving them that support that they need to be able to engage in that is another way that hospitals might be seen to be culpable. So we thought that was interesting, but our data can't speak to which of those it is. And so just leave that as something to explore, which is a great segue to my summary slide here, which is, do healthcare workers think the PBEs are avoidable? Sometimes they do. And when they are, families and hospitals are often factors here. And so that would just be something worth looking into a little bit more. All right, so I'm going to hit you with the limitations. Every research study has them, and I want to be clear about what's going on here, but also talk about some areas of future research. So is this sample representative? Of pediatric hospitals? Maybe, but it would be great to replicate these in other hospitals. Does it generalize to adult hospitals as well? Not as sure. So this definitely is an area where future research is needed. I know that everybody knows this, but correlation is not causation, and this is a correlational study. And so it's unethical to randomly assign people to patient aggression. That seems problematic. So correlation is kind of the best way that we have to study this. But I do want to point out something that's interesting and worth thinking about. So we are working under kind of a loose assumption that the more frequently you experience patient behavioral events, the more likely you are to experience something like burnout, which makes sense. People nod their heads, yes, that makes sense. The reverse is also true. The more burned out you are, the less likely you are to have the cognitive resources and the engagement to be able to de-escalate patients effectively, which is also going to likely lead to higher frequency of patient behavioral events. So it's just important to understand that that's likely to be a reciprocal causation kind of situation, and that our study doesn't speak to it being one direction or the other, and we would expect it to be both. Also, as I mentioned earlier, we focus on physical aggression incidents only. We know that verbal aggression is rampant. We know that it is a problem. We know that it can lead to psychological effects. So that's another area where future research is definitely needed. And our attempts to take a look at what can help were pretty not great. So we haven't really been able to find what those protective factors are just yet. And certainly more research is needed there. All right, so in sum, this first study helped to define the problem a little bit better. Didn't solve, I mean, no first study does, but there's a lot more that needs to be researched. Ooh, somebody raised their hand, which I can see.
Yeah, hi, this is Sabrina Freeman. I'm one of the remote participants. I just wanted to say, one of the things that stood out for me in the sharing, one of the questions that I have, my good piece, how people hear about it. I anticipate there might be a difference as to whether they're hearing about an incident through a controlled communication, through an opportunity to interact and ask questions about it, where some, as opposed to the sort of randomly disseminated, hey, did you hear about Joe that got into this incident, and the kind of story that may build up around pieces. And I wonder if there's an area for research there of is there a difference in, because that feels like a place where we could take some different approaches later too, of speaking openly about things that have happened versus just allowing that communication to be more informal.
Absolutely. No, it's a great question. And I think it's really interesting. And I would agree that a lot of times what we hear about is the more, I don't want to say gossipy, it sounds so negative, but like the more grassroots kind of spreading of, oh, did you hear what happened to so-and-so and this kind of thing, that we are thinking about that. But also, of course, in these safety huddles, like you were talking about, that maybe this information is disseminated through more official pathways. And so being careful about how we disseminate the information might be another really important area of research to try to keep these ripple effects from being so negative. So I think that's a great question. Thank you. All right. So the key takeaways here, the study had a lot, but in terms of what's actionable, there's just clear evidence that workers' compensation data is really insufficient to capture the harm that's happening from patient behavioral events. This really tends to focus on the physical effects of these types of things. And we know that there are psychological effects. And so that's important. And then also the ripple effects aren't captured oftentimes by workers' compensation data because that tends to be really focused on the person who was targeted by this behavior. Another takeaway is that each patient behavioral event can lead to these ripple effects. And so it's really helpful for leaders in an organization to understand that this effect is not isolated to the person who was targeted. Expectations and avoidability may be some avenues to explore, but certainly there are a lot of other avenues to explore as well. So before I move on to my next, my plans for future research, I wanted to just thank the people who helped with this study. These are a lot of folks who are from the Solutions for Patient Safety who helped open the door to those hospitals and getting in to be able to do that research. My graduate students and my undergraduate students who helped out with this, and of course the participating hospitals who were in this study. So in terms of what's next, the future research directions that I've got, so I was able to present this research that I just presented to you to this national learning session of the Solutions for Patient Safety in St. Louis, Missouri. This was in May 2023. I presented this. I met a bunch of healthcare workers. There were like 400 or 500 healthcare workers from over 100 hospitals there. It felt like I was doing like a Super Bowl halftime performance or something. It was awesome. Minus the backup dancers, but maybe next time. But I listened and most importantly learned. So the National Learning Session lived up to its name. I learned a lot about what hospitals are thinking about with patient behavioral events. And one of the biggest questions they had is how can we help staff? They want to be able to help, they don't know how to help. So I broke it down in the way that I do, which is through this framework of primary, secondary, and tertiary interventions. A primary intervention strategy is focusing on reducing PBEs. These are things like engaging in de-escalation training or behavioral emergency response teams, which are increasingly popular in hospitals. A secondary intervention strategy is to reduce the outcomes. So you experience the event, but how do you keep people from having these negative psychological outcomes from this? So making sure that you support somebody's sense of autonomy and control can be an important way that you might be able to support folks with a secondary strategy. And then social support also plays a role here. Tertiary intervention strategies are how do you help healthcare workers cope with the outcome? They've experienced the thing, they've experienced the outcomes, and now how do they manage that? So that can be things like counseling, referring people to EAPs, and workers' compensation support. Now, in talking and listening to the healthcare workers at this national learning session, what I realized is that there was a lot going on in primary intervention strategies. They felt okay about their tertiary intervention strategies, and they had a lot of questions about here. What could we do that would fit in this category? And that's what led me to focus on social support as the area where I'm going to do my research next, or where I am doing my research. So we engaged in a literature review of peer support programs. So this is an already existing set of programs that are in a lot of different hospitals. And we wanted to see what was going on in these peer support programs and if they covered patient behavioral events. So this is, I'm kind of a selfie fanatic, but these are all of my grad and undergrad students at a pizza party that we had at my house. And they're the ones who helped out with the lit review, so I wanted to thank them for that. These peer support programs are popular in healthcare. There's a lot of them, but they also cover first responders will have these types of programs, and also the military will have peer support programs. So our lit review, we wanted it to be inclusive across these different occupations. And what we found is that the focus is really on secondary stressors. So these are, I am exposed to a traumatic incident and that is causing me trauma. And so you can see how in healthcare and in first responders and in military experiences, you're going to see traumatic things that you're not the person who's like directly traumatized, but you had the secondary traumatic exposure. We feel like patient aggression is really more of a primary stressor, and that these peer support programs don't really quite hit the nail on the head with regards to supporting people who have experienced this. So what we have identified as what's different about patient behavioral events is that you've got two roles. You've got your role here as a helper and your role as a victim or a target of this patient aggression. And that introducing this role as a victim or target leads to some conflict, because now you have to be helping the very person who has been aggressive towards you. That is psychologically complicated. That's not a place where your brain wants to go. And so we think it's important to really look at it through this lens. So we're engaging in a pilot to expand a peer support program at a hospital, and we're expanding it to specifically include support for patient behavioral events. So one of the ways that we are expanding this is to talk about some possible team responses. So we know there are ripple effects. How might teams respond when there's been a big patient behavioral event in a unit? And one way that they might respond is through overprotection or indignation. So that's what all these little guys are about. This is your team. They're upset that you have experienced this patient behavioral event, and they may be overprotective of you, which may cause you to lose some confidence in your ability to provide good support and help for patients. And then they may also be indignant on your behalf. How dare the hospital put you in this situation? How dare this patient do this to you? And those are all natural and normal responses. So in the peer support program, what we're trying to encourage is some support for depersonalizing the incident, that the incident wasn't necessarily at you, but it is a result of a lot of different things going on in a situation. So that can help you get over that sense that you were singled out for this. And then reviewing and reminding people about the organizational strategies for safety could be really helpful to avoid that sense of indignation at the hospital, and making sure that peer supporters are ready to talk about that in a way that feels appropriate to that situation. We also want to expand the peer support program to explain this role conflict. Just lay it out like I just did for you. This is what is likely to happen to you. And so that you can make better sense of your emotional reaction, and that you're going to have this potential for conflict within you. Talking about good emotion regulation. So when you're in this role as a victim or target, how do you settle your emotions down? Standard stuff, deep breathing, sensory grounding, those kinds of techniques. Asking peer supporters to watch out for rumination. It's very easy to keep going over the event over and over and over again, and how to refer that person to professional support to help them with that. Restraint overuse is a very common response to experiencing patient behavioral events. So that's also a concern. We want to try to encourage the building of a healthy self-narrative where you can kind of resolve this conflict for yourself so that you can get restored to a good level of job confidence so that you can engage in the good work that you need to engage in. So in summary, we're going to publish this literature review. We're working on writing it up right now. And we're going to conduct this pilot study of the peer support extension to be able to see if it's helpful to have peer support cover patient behavioral events. So you're welcome to contact me if you have questions. I know we're almost out of time, but at lisakath@stsu.edu, that's my email address. You're welcome to reach out, and I'm happy to answer questions here.
One comment that we can follow up later, and then I have a question. The comment is that you should also be thinking about social support as from a primary prevention perspective. It could be secondary, primary or secondary.
Oh, yeah.
More broadly, we can talk about that, because there are ways that social support and peer support can be a primary prevention.
Okay, cool. Love it.
Building up resources in advance of those experiences.
Great. And the comment was, just for the folks listening at home, that social support could be a primary or a secondary intervention. So, okay.
And then the
We looked at nurses, providers, and ancillary staff. That was the way that we were able to divide it up. And the experiences of patient behavioral events scaled with the amount of time spent bedside, as you might expect. And so we haven't dug further into those analyses, but that's what we found. Yeah, thank you. Did you have a question? Yes. Okay.
So in the initial wave, everybody in the ICU who wound up critically ill. After that, and after the vaccine became available, virtually 100% of the people in the ICU were unvaccinated. So it kind of served as a surrogate for perhaps some elements of structural
Mm.
and the thing that was interesting was I expected a lot of the people's response to having a family member hospitalized with serious illness is really unpredictable until that's happened. But I'm wondering, you know, now thinking about what's going on, whether particularly the pediatric that overrepresentation of people being hospitalized with
Yeah, well, it's a great observation. So just to repeat that or recap it, and hopefully I do it justice, is that there may be an overrepresentation of people who are hospitalized, of people who are unvaccinated, and may represent some level of mistrust or hostility towards healthcare workers or the medical field in general, and whether that may have an influence on why we may see an increase in aggression. I think that's a great point. Another thing that I didn't have a chance to talk about in this talk was at one of the 3 hospitals, they wanted us to include measures of experiences and witness/heard about experiences of family and visitor aggression as well. So we focused on patient aggression as one angle of it, but the family and visitor aggression, I think, is going to be much more likely to be associated with that you're talking about. So it's a great point. Thank you. Yeah.
What was the age of the patients? The same, the psychological effect, the same, if it's a young child.
Yeah, that's an interesting question. We didn't ask because we were really trying to aggregate across, you know, like all these different people within a pediatric hospital. And so I think in the psychiatric or in the behavioral health units, they're much more likely to be adolescent. But the age ranges were from, we did not include the NICU. We felt like that they weren't really capable of patient aggression. So we did exclude them. But everything else, you know, from 3 up to 18. Thank you.
Yeah, thank you for sharing your work with us, Lisa. Very interesting and important work. And thank you all for joining us today. And then she has her email here. You're very welcome to contact her if you have any questions. Yeah, have a great, enjoy the rest of the day.
And I'm just going to add, if you guys have additional questions, then you are absolutely welcome to email me because I like this topic a lot. So I'm happy to talk to you guys about it. Thank you so much for having me.
Thank you.
Appreciate you guys.
Thank you.